Good morning to everybody. Hello. Okay, Larry, I'd love to say it's a bright sunny day in Columbus, but we'll wait. But thank you for joining the One Ohio Recovery Foundation Board of Directors July meeting. I'll start by thanking the State of Ohio Library for hosting us today. Thank you. We have formed a partnership with them to move forward, making our meetings more accessible for people to attend. I would like to now ask Lori to do the roll call.
Bambi Vaughn.
Here.
Julie Amon.
Here.
Tom Whiston.
Here.
Mircha Handrew. Matt Old.
He's out in the hallway.
Don Mason.
Here.
Greta Mayer.
Here.
Glenn Miller. Ron Luce.
Here.
Betsy John.
Here.
Jeanette Worsbicky.
Here.
Judy Dodge. Denise Drehaus.
Here.
Keith Hojado.
Here.
John Tyler Lee. David Mattia.
Present.
Wayne Piccirilli. Greta Johnson.
Here.
Scott Silac.
Here.
Tom Gregoire.
Here.
Larry Kidd.
Here.
Robert Radcliffe.
Here.
Michael Royson.
Here.
Rachel Baker.
He's up there.
Evan Kleemeyer.
Oh, I'm promoting him now. He is here.
Terry Johnson. Bill Flumer.
Thank you very much. We would also like to welcome our guests, both those who are here, those who are virtually joining us. If you cannot, we cannot hear your comments if you're calling in online. So again, if you would just send an email to info@oneohiofoundation.com, and we'll try to read your email as quickly as possible and respond. Our first order of business is to approve the agenda. As you have noticed, we've opted to move our committee reports to the August board meeting to make sure we have time today for our executive session, strategic planning. Does anybody have any edits for today's board meeting? Hearing none, is there a motion to approve the agenda? Dr. Michael Rosen has moved to approve the agenda. Is there a second?
Second.
I think Jeanette second. Any discussion? All in favor, say aye.
Aye.
Opposed, and the motion carries. Next is approval of the draft minutes from our June board meeting. The draft minutes were in your packet, and I have a motion to approve the minutes.
Motion approved.
I think, oh, we have a correction. Go ahead, Tom.
Well, under updated fiscal policy, it has, under number 4, it just has grantees receiving, and it looks like 750,000, but there's a 0 missing on it.
Okay, just a clerical.
Just clerical, yeah.
So we'll make sure it says 750,000. Thank you. Let it be noted that is there a motion then to approve the minutes with that correction
Motion approved as amended.
by Director Amon and seconded by Director Kidd? Any discussion on that? Hearing none, all in favor say aye.
Aye.
Opposed, and motion carries. Our next item, I'm honored to introduce our special guest for today's meeting, Dr. Richard Whitney. Dr. Whitney serves as the Medical Director at Ohio's Professional Health Program, which supports the well-being of Ohio's healthcare workers. Following several years of practice in emergency medicine, Dr. Whitney completed a fellowship in addiction medicine in 1991 has practiced addiction medicine ever since. We're happy to have him with us today and share his insights into the history of addiction and its implications and long-term solutions. With that, thank you, Dr. Whitney.
Thank you very much for the invitation to speak to you today. I was asked actually to put together a presentation on the history of addiction and bringing it up to the present, which I think has direct bearing on the good work that this organization is doing. But this is, again, to emphasize a couple of things that might be obvious to some, might not be as obvious to others. And that is addiction is treatable. Addiction is not at this time curable. It is a long-term problem requiring long-term solutions. I'm gonna make sure I am, there we go. And that is your speaker right here, and I've been around for 30 plus years now. Hard to believe in the field of addiction. Addiction goes back and mood altering substance use goes back an awful long time, although we are still in the depths of the fentanyl epidemic, the opioid epidemic in this country, which unfortunately is overshadowing another couple of addictions that actually kill a lot more people, and that is alcohol and tobacco, legal substances. But Amanita muscaria has been center of rituals as documents and evidence going back 6,000 years for the use of mood-altering hallucinogenic substances, primarily in religious rituals. Again, way back then, opium used as a medication as far as the 9th century BC. In talking about opioid epidemics, for you world history buffs, remember back to high school world history, the opium wars in China in the 19th century, where Britain was getting rich and selling opium to the Chinese, and there were literally tens of millions of Chinese addicted to opium, and the wars were started by China in order to stop the decimation of society, because the Chinese were sitting around in opium dens smoking opium rather than tending to the fields and so forth. And recreationally, oldest seeds of vines, meaning of course vineyards, go back, at least documentation, to 7,000 to 5,000 BC. So somewhere between 7,000 and 9,000 years ago, alcohol was being pressed from vineyards. So this is not a new phenomenon in our society. Treatment, addiction medicine, my own field of addiction medicine is not a brand new field, although the American Board of Addiction Medicine, and now it is a subspecialty under the American Board of Preventive Medicine, is relatively new. Aristotle talked about alcohol withdrawal 384 to 322 BC in that area, and Roman physician back 25 BC, he lived 50 AD, talked about dependence on intoxicating drink as being a disease. So the idea of this being a brain disease, again, is a rediscovery of something that's over 2,000 years old. And a Dutch physician, Nicholas Tult, I'm sure I'm not pronouncing that correctly, adapted theological models to explain loss of control that was formerly considered to be sinful behavior. Does that sound familiar in our society? A lot of times, bad people are using mood-altering chemicals. And he said, hey, maybe we have some medical explanations for this. This goes back to the 1600s. Okay, yeah, let's do this again. There we go. All right. This is the most recent definition of the disease of addiction. This is by one of my parent organizations, the American Society of Addiction Medicine, which says that addiction is a treatable, very important word, chronic medical disease, not bad behavior, chronic medical disease, which involves complex interactions among brain circuitry, a brain-based illness, okay, not bad behavior, genetics, one of the two key things that makes it more likely for an individual to have a substance use disorder in their lifetime are inherited genetics and age of onset of use of mood-altering chemicals. The environment, in other words, if we lived in Saudi Arabia, where you get your hand chopped off, I think if you drink alcohol, then it's much less likely that you're going to develop an alcohol use disorder. But if you have a chemical culture like we live in now, with tranquilizers, sleeping pills, opioids, stimulants, marijuana, alcohol, then it's much more likely we're going to be exposed in our lifetime, oftentimes at a young age. And an individual's life experiences, people with addiction engage in behaviors that become compulsive and continue despite adverse consequences. Continue despite adverse consequences with a key hallmark diagnostic criteria for the diagnosis of substance use disorder. For any of you who still, unfortunately, might use the outdated, outmoded, incorrect diagnostic terms, substance abuse, drug abuse, alcohol abuse, please leave it in this trash can on the way out. The diagnosis is a substance use disorder, an alcohol use disorder, an opiate use disorder. These are non-stigmatizing, non-shaming phrases that more accurately describe what's going on and do not dissuade individuals from seeking assistance. Would you rather go get help if you're going to be identified as a substance abuser or someone who has been diagnosed with a substance use disorder? Okay, the progression is no substance use. Okay, we all start out that way, of course. Low risk use, hazardous at-risk use, which used to be termed abuse, which is no longer an accurate diagnostic criteria. Then harmful use and progressing to a substance use disorder, which in most cases is equivalent to an addiction or an addictive disease. Now, 4 important points, take-home points. This is, again, very important to understand this is a chronic illness. I emphasize that because when I started in the field of addiction in 1991, we still were not kind of, is it addiction or is it physical dependence? Are these the same thing? And once we detoxify someone, aren't they no longer addicted? So over time, the brain circuitry and the reasons for cravings and relapse have been pretty well worked out. Not perfectly, of course. We understand a heck of a lot more than we did 35 years ago when I first came into it. So we now do not use the word detoxification. I've never detoxified anybody in my life. The liver detoxifies the body. I manage withdrawal symptoms to prevent seizures and so on and so forth. But the chronic illness will continue even after the individual is physically removed from their mood-altering substance, whether we're talking about opioids or we're talking about alcohol or whatever. It is a treatable illness, okay? It is not hopeless. And again, I know people in this room are not, you're in the general public, but you have a lot more knowledge and information than the general public does. But there's still a lot of people that believe that relapse is inevitable. Nobody can say in sustained remission. Every alcoholic always goes back and starts drinking again. Well, that is not true. We actually have excellent treatment. We have developed marvelous models of treatment and medications that can treat addictive disease quite effectively and dramatically lower the return to use. Still, in the general public, individuals who do complete a quality treatment program without monitoring and follow-up, still about 50 to 60% will return. That sounds awful and it really needs to be improved. But if you think about other chronic illnesses like diabetes, asthma, emphysema, chronic congestive heart failure, cancer, and others, those chronic illnesses also have high relapse rates. So it's no worse than the general public. But what I am involved in now with the Ohio Professionals Health Program is chronic illness management. And to make it ultra short, we keep an eye on these folks for 5 years after treatment and lower the return to use rate to less than 10% in our program, and around the country, less than 20%. So we have a model that really works to dramatically lower the relapse rate if we can just emphasize that. The 2 best quality programs that have the lowest relapse rates are professional health programs and drug courts. It is a progressive illness. In other words, people don't stay the same. Quantity of alcohol, quantity of fentanyl, quantity of opioids used over time increases, and physical deterioration and social deterioration is the name of the game. So the idea is to get treatment started early before there are infections, before there are heart valve infections, before there's permanent liver disease, before people overdose and die. Because it is a fatal illness. People die from overdoses, people die from chronic organ failure, homicides, suicides, motor vehicle accidents, falls, and so forth. So we want to get the treatment started as early as we can. Important to understand and take home, it's a primary disorder. Again, back in the 90s when I was first coming into it, my initial fellowship and a lot of my practice was in a psychiatric facility, and 1 floor, 1 wing was dedicated to treating patients with addictive disease. But still, there was an awful lot of people who said, well, every alcoholic, every addict, everybody with addiction must have an underlying psychiatric illness that drove them to use mood-altering chemicals. This is not true, because the treatment for that would be, here, take your antidepressant and take your medicine that will eliminate your drive to drink and drug, and that didn't work. I mean, if it worked, I wouldn't be here. With psychiatry would still be the field that treated this disease. So it is a primary disorder, meaning there's nothing underneath it. And it's separate from other disease states. Okay, and again, primary means that there's nothing causing it other than the disease itself. It does not mean that people don't have co-occurring diabetes, depression, anxiety disorders, psychiatric disorders, but those are not the causes. Those are other co-occurring conditions that need to be treated. This is a biopsychosocial illness. What does that mean? It's kind of a word put together to make sure we understand there's at least three legs to the stool: biological, psychological, and social illnesses. Therefore, the treatment needs to be geared toward all three of those primary legs. It is a brain-based illness biologically. It is cyclical. People wax and wane. It is not inevitable that there's one straight line. People wax and wane. They make a commitment to stop, they return, okay? But generally, it's a downhill course as the disease progresses. Early exposure, this is the name of the game, which we're going to see here momentarily. Protracted withdrawal, what does that mean? It means a lot of times, again, people have the belief that once they go for 3 to 5 days on an inpatient unit to be physically withdrawn from their addictive substance, that they're no longer addicted and they're fine. Well, what happens, especially with opiates, especially with potent opiates like fentanyl, is the brain is so altered that it takes months, sometimes up to a year, for the brain to completely eliminate the effects of long-term use of opioids, which includes physical withdrawal, sleep disturbance, mood swings, irritability, anxiety, and intense cravings. And this is what leads people back to using again even months after physical withdrawal. And genetic predisposition has a lot to say about which ones those turn out, so pick your parents very carefully. Okay, biological solution, primary treatment up to 6 months. Again, it would be wonderful if we had a 2-week program, but it takes longer. Bottom line, treatment less than 90 days, we're wasting our time. Treatment has to go at least 90 days in the overwhelming majority of individuals diagnosed with a substance use disorder. That doesn't mean all 90 days has to be on an inpatient or residential level or intensive outpatient, but an engagement with a treatment program needs to go on average, with a great majority of people for 90 days or more before people are going to get well, sometimes up to 6 months.
Any reason why?
I'm sorry?
Why is that?
Because of the profound alteration of brain chemistry that goes on, and it takes months for brain chemistry to start to normalize. So the balance between stimulatory and relaxation brain chemistry, serotonin receptors, and opioid receptors begin to return to the baseline state. It's not like take your antibiotics for 10 days and the pneumonia is gone. It takes a lot longer for the brain chemistry to stabilize after years of drinking and drugs.
Doctor?
Yes, sir.
Is your presentation focused mostly on the opiates, or does it include all substance use? Like, would methamphetamines fall in the same
Yes.
category?
Yes, sir.
Wouldn't methamphetamines be longer? I heard it's more addictive than the recovery is much longer than opiates.
It can be. And again, I'm trying to generalize, but you're exactly right. And although the money for this organization came from the opioid settlement,
Right.
I'm trying to include other chemicals and include gaps of time rather than specifics, because you're exactly right. We have marijuana, we have alcohol, we have stimulant cocaine, we have methamphetamines and others. And the relapse rates vary dramatically. The treatment varies dramatically. The duration of time and the relapse rates vary dramatically from one chemical to the next. You're exactly right, sir. And methamphetamine is really a deadly drug. Medications, we now actually have medications that we can use. We have methadone for opioid use disorder. We have naltrexone orally for alcohol use disorder. We have injectable long-acting naltrexone, brand name Vivitrol, for opiate use disorder and alcohol use disorder. And we have a brand name Suboxone, which is buprenorphine. Wonderful medication. How many medications do we have in our armamentarium in the pharmacy that with the first dose, we reduce the likelihood of death by 50%. And that's what Suboxone or buprenorphine has given us. Once we initiate treatment, the chances of that individual dying from their disease goes down 50%. It's wonderful medication. And then permanent abstinence from mind and mood-altering drugs is an integral part of understanding and treatment for long-term recovery. Not, well, I'll go a couple of years without drinking and then I'll test myself again. Unfortunately, in this day and time, we still don't have the answer to that. Everybody loves graphs, right? Okay, this is an interesting graph. It's from NIAAA. And this is a study done by 2 different organizations in the early 90s, repeated in the early 2000s. And again, the whole point of this slide is to show that the earlier we begin using mood-altering chemicals, in this particular case it was alcohol, which of course is the lubricant of our society, and available to 13, 14, 15-year-olds, just like it is to anybody else. that if we start drinking, if our children start drinking, especially before the age of 16, before this important prefrontal cortex, which is the decision-making part of the brain, matures in the early 20s for women, mid-20s for men. We all know that women mature quicker. But if we start drinking while our prefrontal cortex is not fully insulated, it's called myelin, then the likelihood of developing a substance use disorder dramatically increases from upwards to 50 to 60% if we start drinking at a very early adolescent age, down to about 15% if we let our prefrontal cortex mature. So age of onset and genetics are the two big reasons that we have such a high incidence of substance use disorders in our country. We just need to protect our kids. This is a pediatric illness. If we can just protect our kids from starting, I mean, hopefully for life, but at least while they're teenagers until their brain matures, the likelihood of developing the disease of addiction drops dramatically. Psychologically, denial. I don't have a DUI, I can't be an alcoholic. I can quit anytime I want to. I've done it lots of times. Okay, I don't drink every day, so I can't have an alcohol use disorder. These types of rationalization, justification, and minimization that people with substance use disorders use to convince themselves they don't have the disease. Why is that? Because I don't want to stop using. Because it feels really good to drink alcohol and inject opiates or swallow an opiate pill. It feels good. So people, as the disease develops, convince themselves it's not a problem, I can quit anytime I want to. It's called denial. Co-occurring mental health disorder is very important. I said that it is not caused by an underlying psychiatric illness, but it can be encouraged by anxiety disorders, depressive disorders, bipolar disorder, other mood disorders, and so forth. So simultaneously, we need to accurately diagnose and treat co-occurring psychological and psychiatric conditions. Okay, trauma, very high incidence of post-traumatic stress disorder in our population, unfortunately, very, very high in our female population. High incidence of sexual molestation, sexual abuse, sexual assault, other forms of trauma, child neglect, child abuse, and so forth, assault by one significant other. These lead to post-traumatic stress disorder, increasing dramatically the likelihood of use of mood-altering substances and triggering an underlying substance use disorder if one is present, which is self-treatment for another mental health disorder. I'm depressed. Therefore, I think what I'm going to do is start drinking alcohol, which of course is a depressant drug. Doesn't seem to make sense, but this is what a lot of people choose to do. And if they have the underlying biological predisposition to a substance use disorder, then it can be triggered. So either simultaneous or subsequent treatment. What do I mean by that? Sometimes if you take the focus off the addiction and focus on, well, I'd rather talk about my depression. I don't want to talk about my alcohol problem. Sometimes we have to treat the alcohol problem first, or the opiate problem, or the stimulant use problem first, and then subsequently deal with the psychiatric problem. Some people we have to do it simultaneously, so it's very individualized. But I never want to, I'm not a psychiatrist, but at the same time, I've done a lot of psychiatry in my practice. And we have to individualize care, whether we treat co-occurring psychiatric illness simultaneously with a substance use disorder or sequentially once the brain is able to take in information and process it again, depending on how much disruption there is in the brain. Obviously, the longer I've injected methamphetamine or fentanyl or drunk alcohol or smoked marijuana, it's going to take longer for my scrambled brain chemistry to get back again where I can absorb new information to get well and stay well. And then socially, continued use is negative consequences in our society. Thank goodness it's becoming more and more socially unacceptable to get drunk, to use chemicals, to talk about it, to be seen doing it, which I think is a good thing. Why is the incidence of smoking tobacco going down in our society? Well, it's just becoming socially unacceptable, which I think is a good thing. It's wonderful. And we can't smoke in restaurants, we can't smoke in public buildings anymore. So it is encouraging people to stop using this most lethal of all addictive drugs. And then we get back to Maslow's hierarchy of needs, which some of you might remember from physiology, just survival, safety, love and belonging, esteem, and self-actualization, which is part of treatment. Because what we do when we are active in our addiction is we disregard all that. Safety, self-esteem, family, who cares about that? My only goal in life is to seek out, use, and experience the effects of mood-altering chemicals. So long-term support is necessary. Okay, long-term support. Some people just need a sober living environment. Other people leave the sober living environment for an extended period of time, people living on the street or in unstable housing. If we somehow can provide them a sober place to live and stay, then again, the recovery rate can go up dramatically. If we go back to people using chemicals again, or back into our family who are still drinking and using chemicals, then the chances of remaining abstinent go way down. When we talk about recovery, housing, peer support, 12-step meetings, outpatient meetings, Alcoholics Anonymous, Narcotics Anonymous. AA is very close to 90 years in this country, and of course around the world. Very, very effective means for building a sober peer support. We're real strong advocates of getting involved. And of course, we do have some high schools that have recovery, everybody in recovery that wants to get away from mood-altering chemicals. You go to this high school over there, or this dormitory in college. So anything we can do to support individuals, especially during that vulnerable first year or two, will allow the brain chemistry to stabilize and people to learn how to live sober and desire sober living over using mood-altering chemicals. Okay, biopsychosocial solutions can occur at the same time and over a course of a patient's life, a person's life. Relapse rates without chronic disease management is at least 50 to 60%. I hate to say that in 2024, but it's still true because unfortunately, medicine still takes an episodic view of treatment of addiction. We look at it of, you've been to treatment, it's like you've been immunized. Did you go back and start drinking and drinking again? Because this is a long-term chronic illness that requires long-term support to keep this individual in an environment where they don't go back and start using mood-altering chemicals, even though there's part of the brain that says, boy, I'd like to drink again. Oh, I remember that high from fentanyl. This euphoric recall will occur for weeks and months into the first year or so. The more support we can give, the higher likelihood we are for individuals to remain abstinent. If we can support these individuals, again, what we do at how PHP with licensed healthcare professionals, what drug courts do, is long-term management. There are contingencies. If you go back and use again, then the contingency in a drug court, of course, is go to jail, or in a PHP is go back to treatment, or you're going to lose your license because we're obligated to notify. So some type of adverse consequence is a really good motivator for people to remain in recovery. Okay, because they do have still euphoric recall of what it was like to get high. If we can manage 5 years of sustained abstinence and recovery, then the relapse rate goes down to what the general public is. The general public in North America is about 12 to 14% incidence of a diagnosable substance use disorder at some time in one's life. So roughly, this is not an average group of folks, but because you're not selected randomly, but in a random selection of individuals in North America, there's about a 12 to 14% incidence of diagnosable substance use disorder in that individual's life. And even though someone has been afflicted by a substance use disorder, if they stay clean and sober for 5 years, then the relapse rate goes down to what the general public is. So that's kind of the goal, is 5 years of maintenance. Again, 90%, and again, that's not true. I guess I am bragging. I just did a paper for the Federation of State PHPs last year examining what was in effect with the medical board licensees it's called the One-Bite program. It's now changed to the confidential monitoring program. But we took all the docs in the program and we measured what happened to them after they entered into the recovery program and into monitoring. And 91.7% had 0 relapses at the end of their 5-year monitoring period of time, which is at the top end of what the national statistics are. So we are real proud of that. If we can find some way to generalize that in medicine, to have a monitoring program and a support program for up to 5 years, then the relapse rate will begin to fall. There's nothing unique and different about doctors or anybody else, other than the fact that we're more educated, but we still have the same disease of cancer, diabetes that everybody else does. Same with addictive disease. Yes, sir.
So what's the difference? The medical professionals have more to lose?
No, we got a license. I've worked real hard to get my license. And if I don't do what I'm told to do, then that's going to go to the shredder. And that's the consequence. So the fear of consequences is a really good motivator to do what I'm supposed to do to take care of myself. And that's what monitoring is do what you're supposed to do to get well, stay well, and take care of yourself. Or the contingency is there could be action taken by the licensing board against one's license.
Is there a longer term, do the healthcare professionals get longer term initial treatment?
Many do. Again, it's an excellent question. The standard of care for doctors especially, and most research is done on physicians because PHPs initially started for docs. So I believe it's generalizable amongst nurses and other healthcare professionals. But if we talk about docs and the research, then the standard of care since the late 80s really has been 90 days of residential treatment, which is wonderful. If I had a magic wand, I would grant that to everybody because it's a wonderful level of care. Of course, it costs between $60,000 and $75,000. There's a whole lot of people that can't afford that. So what the medical board in Ohio has allowed us to do is defer level of care and length of treatment to qualified treatment providers. And what we found is, of course, depending on the individual, the length of addiction, the drug of choice, and so on and so forth, is less treatment at less cost for a shorter duration period of time for primary treatment can be very successful in motivated individuals. So what we're doing is we're saying, maybe doctors know what they're doing. And if we stop saying that everybody with breast cancer must be treated only one way for one duration of time, maybe when we individualize it, we'll get good results. And that has happened in the field of addiction. That less intensive, less expensive, less duration quality of primary treatment, very importantly, coupled with monitoring, because without that second portion, then the shorter duration treatment is not going to have as good a results. But when you couple it with intense monitoring, periodic drug screening, periodic meetings with case managers and so forth, support, enforcement of attendance at recovery meetings and so forth, then that's what boosts it up. And personally, I think the subsequent monitoring is every bit as important as the primary treatment. It really is. Yes, ma'am.
Just to follow up about quality, I know you just listed a bunch of things that are important integral ingredients to recovery, but are there other things you haven't mentioned yet when you refer to quality substance use treatment?
Yeah, that's because I only have 20 minutes. But yeah, good quality. I mean, proper diagnostic assessment, identification of co-occurring illnesses, referral to appropriate psychologists, individual counselors, psychiatrists for medication management, and aggressive treatment of chronic pain conditions, which sometimes could be relapse triggers. So full assessment, quality treatment, and long-term monitoring. But yeah, the initial part is, I'll come back and talk for 2 hours on that. Okay, and again, this is not unique to Ohio PHP. It's just, we are very, very, very fortunate at this time to have enough funds to be able to have individuals that we can collect this data, hopefully in the future with some assistance, to be able to present this data. But there are publications amongst the longer PHPs that essentially duplicate what I'm talking about. It's not unique to Ohio. Yes, sir.
Yes, Eli Lilly is starting a randomized treatment with the GLP-1 Mounjaro for this based on anecdotal success. Have you seen any of that?
No, the results aren't in yet. I mean, short-term results. I mean, but it's only been a few months since someone said, hey, they're drinking less. So that would be a wonderful event if that were to occur, and we would have yet another medication on our armamentarium. But the data is not out. We look at 6 month and 12 months data, but that's useless basically. What we want is 2 to 5 years of data, and that's not out yet because those studies are not studied. Yes, sir.
Richard, could you mention SBIRT and the role of mainstream medicine as opposed to the siloed system we have now?
I'll try to put that in, but SBIRT is screening, brief intervention, or referral to treatment, which has been around for a long time, but is essentially a packet of questions. So primary care physicians will not simply say, I don't know what's going on, or I don't know what, they will be able to effectively screen patients as you're coming in for blood sugar checks or for blood pressure checks. By the way, let's talk about drinking, chemical use. If the answer is positive, here's a brief intervention. And if that's not effective, then we'll refer you to treatment. So including all of medicine, especially primary treatment providers, OBGYN, family practice, internal medicine, and so forth, into the system for screening and referral to treatment, I think will make a dramatic difference. unfortunately, there's a lot of primary care docs who still carry with them the societal prejudice about addiction being untreatable. I don't want to talk about it because I don't want to anger my patient and so forth. So if we can, take the curtains and open them up and encourage our primary care docs to get involved, to screen, and then have an idea of what to do with them if there's a positive screen, then I think the incidence of successful treatment of this horrific disease will go up substantially. Because again, what Greg mentioned is a lot of medicine is siloed. Here are the cancer treaters, and here are the diabetes treaters, and here are the addiction treaters. What we want to do is kind of generalize that, because primary care physicians screen for cancer and primary care physicians screen for diabetes, so they treat diabetes. But what we want also is screening and referral to treatment for the disease of addiction, for alcohol, opiates, stimulants, and others, and take away the shame and stigma associated with the disease of addiction. Okay. All right, so that was a lot. Alcohol and drug use and addiction have a long history. We are going through this terrible opioid epidemic in this country. This is not the first time. Hopefully it's the last time, but it's certainly not the first time. Addiction requires long-term solutions, not just short-term, brief. What used to be called detoxification, we call it withdrawal management now. It's a biopsychosocial disease requiring a complete, comprehensive psychosocial treatment over time for support. And there is hope. We got models that work now. It's not just a coin toss. It's not just what used to be called detox and 12-step, physical withdrawal management, and then referral to a 12-step program. Sounded good, but that's all we had 35 years ago. But the sustained success rate was very, very low. Now we have medications, we have more effective treatment, we have monitoring, and we know how to treat it. If we can just get the finances out there, if we can just get the models expanded, then we can make a dramatic impact around the country. So this is us. This is the last slide. I'll stay here all day or 2 minutes or whatever for any other questions that anybody might have. Yes, sir.
You were great. It's unfair you only had 20 minutes, but I have a workforce kind of question. You went into addiction medicine a long time ago. I'm not sure it's even fashionable today. How do you get more, third-year residents or first-year residents to start thinking about going into this subspecialty versus orthopedic surgery?
Ooh, good question. And fortunately, we are now I say we, usually me, but Ohio PHP presentations are now included at the University of Toledo Medical School as part of the curriculum for first-year students. So what we want to do is start educating first-year medical students, second-year medical students, third-year medical students as to, if you're going into primary care, here's what you need to know. If you're considering psychiatry or addiction medicine, then here's the pathway to do it. Because you're right, it's not fashionable. Psychiatry was so poorly paid in the past that people stopped going into psychiatry, leading to the incredible shortage of psychiatrists now. Trying to get an appointment with a psychiatrist, it'll take you 6 months to a year. Addiction medicine is not fashionable. I mean, we're not talking about, well, I'm a cardiovascular surgeon, I can brag about it. When I'm in a social situation, I say, what do you do? Well, I'm in addiction medicine. Oh. So it's, and the pay is kind of mediocre. So it has to be somebody that has a special interest. Why would they have a special interest? Well, because somebody in their family was afflicted, okay? Very often, those of us who go into the field have been personally affected by the disease of addiction. So that's a big motivator. But I gave 99 talks last year to a variety of healthcare organizations, to hospital systems, medical schools, residency programs, and so forth, trying to get the word out. So if you have any other suggestions, I'm all ears.
Who do you lobby on pay, like CMS or who would you lobby for on pay? CMS, pressure on private insurance companies? I mean,
well, private insurance companies, by and large, like for psychiatric diagnoses, pay 25 to 30 cents on the dollar for what they'll pay for an expensive procedure like heart transplant surgery. So it is poorly remunerated. Why is that? Well, if you stop paying very well for treatment of glioblastoma in a 3-year-old child or a leukemia in a 10-year-old child, then there's going to be a national uproar. Who's the poster child for addiction? Addiction still has a negative stigma, even though it is the truly and genuinely the number one and number two killer in our country. People don't pay a lot of attention to it. They pay attention to diabetes, which is important. I'm not taking away importance. But because, and alcoholism, as alcohol use disorder has been found to be a main cause of 7 different types of GI cancer, six types of GI cancer plus breast cancer. So it is the underlying cause, just like we finally connected tobacco use to lung cancer and heart disease. We need to more vocally say the reason that cancer is going up is because we live in a chemical culture and people are drinking alcohol and so on and so forth. But it's a slow process. Those of you who are younger than I am, which is just about everybody here, might remember back in the 50s, if you had one disease, you never disclosed it because it was kind of dirty. Cancer. And young people don't say, what? You want to talk about cancer? What's the deal? It's caused by viruses and genetics, environmental. Yeah, but back then that was unknown. So now we talk about leprosy, we talk about cancer openly. And my hope is that we will more and more discuss the disease of addiction. Unfortunately, we had to have this horrible trigger of the opioid epidemic to force it, into the general public's knowledge. But if we talk more about the effectiveness of treatment and encourage more primary care docs to go into it and destigmatize it, so docs aren't afraid to ask a patient coming in about their drinking and mood-altering chemical use. One of the most underutilized medical diagnostic tests is the urine drug screen, because there's a lot of stigma. Well, I'm sorry, but I'm going to have to. I want to get a urine. Oh no, the doctor doesn't say, well, I want to go ahead and get a urinalysis, and I want to check your metabolites, I want to check your blood count, and we just get a routine urine drug screen. Because most people come in aren't going to say, I'm using methamphetamine, I'm using fentanyl, I'm using hydrocodone excessively. So it's by openly talking about it, people like you that have more of the power of the purse strings than I do, to encourage people to talk about the disease of addiction, how it is a treatable illness, how it's a brain-based illness, it's not shameful or embarrassing, and it's not sinful, and it's not caused by evil spirits. We have never had in the world chemicals like we have now. High potency marijuana, fentanyl, cocaine. In Bolivia, you chew a cocaine leaf just to get the energy to carry up heavy loads at 15,000 feet. Well, it's less than 1% coca. But now crack cocaine is 80% pure cocaine. Fentanyl, 20 years ago, if you told me somebody's coming in for treatment of a fentanyl addiction, I'll give you 100% certainty it was an anesthesiologist or a nurse anesthetist, because they're the only people that had access to it. But now it's manufactured and imported, and nobody uses heroin anymore. Everybody uses it. So we have different chemicals, we have pipelines that bring the chemicals into society, and we have a culture. I mean, just watch a football game or a baseball game. How many alcohol commercials are on there? And alcohol and tobacco are essentially gateway drugs. I'm not critical at all for decriminalizing marijuana, simply because the treatment for using marijuana should not be imprisonment, any more than drinking alcohol should cause someone to be put in prison, because that's not effective to stop people from using it. But if we can talk more openly like we're doing today, then you can go home to your home environments and talk about treatment works. There are good quality treatment programs, et cetera, then we destigmatize it and get more people into treatment and get well. That's a long answer. Yes, sir.
You said you did over 90 presentations. Was that throughout the country or just in Ohio?
Oh, just in Ohio. Well, the 2 were out of state. But
It's my understanding there was discussion about having some loan forgiveness at the federal level for those that go into treatment, whether it's mental health or substance abuse. And Dr. Johnson, maybe you can talk about the state. I heard that there was discussion, maybe it was over at the chamber, not at the legislature, but perhaps having loan to drive more people into the field.
Ooh, what a good, that's the first time I've heard of that. What a
Dr.,
wonderful.
is there a discussion of?
Yeah. Monetary incentives have been found to be very effective, especially in people in poorer neighborhoods. Because if you go in and you produce a negative drug screen and you get a $15 gift card from McDonald's, that can be shockingly effective. when you're talking about physicians, you're gonna have to talk about, loan forgiveness would be a really nice carrot to go after. So I think it's a wonderful idea. I've not heard of that specifically, but I think it's a great motivator.
We have 2 legislators here, so you can.
Oh, wonderful. Whether that's on the state or the federal level, it's wonderful.
Dr. Whitney, I just want to thank you for sharing your many years of experience and research and insights. One of the things I miss about being in college is having opportunity to learn from people who are extremely learned, such as you. Hopefully we can bring you back and you can share more.
Anytime, just let me know, I'll be happy to. Thank you very much.
I've been given instruction by the boss that I'm going to skip item 5 in the agenda and move on to item 6, which is the June financial report. There's Jim Flynn. And he'll be covering the 2023 financial statement details.
Good morning.
Morning.
Today, we'll take a few minutes to talk about the mid-year budget status and cash balance reports. As a reminder, our fiscal year is a calendar year, so January to December, and so we are now at the midpoint in our fiscal year in the budget. So in the board books, on the screen, and for those of you at home, you can find the reports in I think meetings, board materials. And also down there for your review. So in June, we obligated some little more than 102,000, which brings us to a year-to-date total of just over $500,000. This represents a little bit more than a quarter of the budget that you approved last December. So from a budget standpoint, we're in really good shape at this point in the year, heading into the second half. You can switch on to the grant. So the other part of our operating is in the grant support budget at the bottom of this screen. In June, we spent $23,500 in that area for a total of $111,000, which represents around 30, a little bit more than 30% of that grant budget. So we're also in good shape there. And as
Just to make sure everyone knows, we're on a calendar year.
Yep, we're on a calendar year. Yep. So this is our midpoint. Let's flip over to so for the cash balance report, our cash position increased by 16.8 million in June. About mid-June, we received Janssen year 4, 16.5 million for Janssen year 4. We continue to earn in excess of 5% interest, so that's around 440,000. Our net operating disbursements, actual cash disbursements, were around 120,000 for the month, which gives us a positive change of 16.8 million for the month. We expect to receive distributors year 4 by the end of this month. And just a couple of weeks ago, the National Administrator sent us the first payment schedule for this summer. And so I expect by the end of August, I suspect maybe before that, by the end of August, we'll receive 91.6 million from Walgreens, Walmart, CVS, Allergan, and Teva.
How much of that is advanced, like the year 18?
None.
So the 91 million is just this year's.
It's year 1. It's year, because we're behind on these. It's year 1 and 2. So Walmart, it's year 1 and 2. Walgreens, year 1 and 2.
And just to call people's attention to one more thing up there, the 16 million and the 3 million, if you look at those prepayments, those don't equal the 27 million. So they're discounting, and that's something we'll cover later.
Yeah. any questions?
Yes, I noticed on the operating budget that all of the figures are well over 50% for the year.
Yes.
So how are we dealing with that, and what do we have to shuffle in terms of money to, if this is what we budgeted?
Yeah.
How are we making up for, I'm assuming we're gonna spend more than 100% for the year.
I mean, in all of our budget categories, except for the computer, we're well underspent. Now, we have some expenditures that will hit this fall. Insurance is an example. You see on here, insurance, right? We've only spent for some business insurance. Our insurance renewal will come up in September, and at that time, we'll spend another $120K on that. So those
It's
percentages are
balance
related.
remaining.
It's the
Oh, yeah,
remaining
yeah.
balance.
It's not spent.
Yeah.
Oh, the percentage remaining, I
sorry, yes.
apologize, I
I'm sorry.
didn't understand that.
Yeah. Sorry about that.
Yeah, and I know we glanced over to the grants update, so I did want to share some very exciting updates with you all. And that is that as of this week, all 19 of our regions are reviewing grants. So thank you all so much for all your help.
Thank you. Is there a motion then to approve the June unaudited financial report?
So moved.
By Mr. Kidd, seconded by David. Any discussion? All those in favor say aye.
Aye.
Opposed, and the motion carries. So we have now concluded the business up until the executive session. So I'd like to move shortly into it. We want to remind our guests and all of you that our next meeting will be right here at the State Library. Again, it'll be 10:30 to 12:30. I don't have the August date with me. It'll be the second Wednesday, yeah. So at this point in time, is there a motion to go into executive session for the purposes of employment, training, and legal matters?
Mr. Chair, I'm sorry. Before we do that, may I just make one comment? My apologies for being late and missing this agenda item, but I was virtually at our last meeting and would appreciate the minutes reflecting that. I think I was on the wrong link, so you probably didn't see that I was there. Thank you, and my apologies for the interruption. I do move approval
So we'll
going
just,
into
we'll make
executive session.
a note to the record on the minutes. Thank you,
Thank
Don. Thank you very much. So then is there a motion to go into executive session for again, legal, what I say, legal matters, training and employment?
Director Tyler Lee has made that.
I'm sorry, my Bluetooth in my ears was picking up my cell phone. So anyway, I'm sorry, who made the motion? Don did. Second was Dr. Rosen, whose nickname was Froisen. All right, we'll have a roll call on the motion for executive session then. We were doing nicknames last night for everybody who missed the meeting.
Bambi Vaughn,
Yes.
Julie Amen,
Yes.
Tom Whiston,
Yes.
Matt Old,
Yes.
Don Mason,
Yes.
Greta Mayer,
Yes.
Ron Luce,
Yes.
Ted St. John,
Yes.
Jeanette Worsbicky,
Yes.
Denise Dreehouse,
Yes.
Keith O'Hoddle,
Yes.
Don Tyler Lee,
Yes.
David Mattia,
Yes.
Greta Johnson,
Yes.
Scott Silac,
Yes.
Tom Gregoire,
Yes.
Larry Kidd,
Yes.
Robert Radcliffe,
Yes.
Michael Roizen,
Yes.
Rachel Baker,
Yes.
Evan Kleemeyer,
Yes.
Terry Johnson.
Yes.
We'll take a few minutes to adjourn, but we are in executive, for recess. We are in executive session.